very simple test.
Okay, so this was our last case. John, go ahead with your teaching point.
All right, you flex the patient's elbow to 90 degrees, and you can do it on your own. And then you take your finger
Good
and
test.
go behind the flexor tendon.
Yep.
Not the flexor, I'm sorry. The um, biceps tendon, which is the supinator. And if you can feel it, pull
Yep.
up on it, and it's intact.
Yep.
You feel it?
Yep. I feel it.
So it's a very easy test to do. You have to make a muscle a little bit, then that makes it easier.
What if we don't have muscles? Okay. Thank you, John.
So that's a simple diagnosis, very easy to do.
Great. Thank you. Okay, Tayson, we're moving on here. What do you think? This patient had anterior elbow pain.
Anterior elbow pain. All right, so yeah, looking at the brachialis, I'm not sure I see a attachment on the
Yeah.
ulna.
So here, and this can be a little bit difficult, but there's actually abnormal signal intensity within the muscle here, even though this is only T1 weighted images. This is a very old-fashioned study. Uh, and actually, let me give you a better one. We can see some of the fibers coming all the way down, so it's not a complete tear, but this was thought to be a partial tear. This would be much better seen in the current days when we have PD FAST images. So let's forget about this one. Take this one instead.
Okay, rule out biceps tear. Looks like we have some disruption of the uh, brachialis insertion, some of the proximal attachment.
There we go, right there.
Yeah.
Good. Yeah. And then here are the axial images. This is an axial T2.
Yeah, so the more lateral fibers of the insertion.
So the biceps looks nice and black here, but here we can see that some of the insertional fibers are actually disrupted. And so this was a partial tear of the brachialis. This was in a Major League Baseball pitcher. Okay.
All right. So it looks like there's a lot of edema in that distal brachialis muscle belly.
Yeah, so we can see it here, and we can also see over here on the axial T2. This is the PD fat set, and this was a partial tear of the brachialis muscle. This one. And you can see that most of, go ahead, John.
I wouldn't use the word belly. The belly is upstairs. That's the attachment.
Okay. So, and here we can see that the bulk of the attachment here are these muscle fibers that attach directly to the bone.
And the fibrous um, structure of the uh, muscle is very, very uh, short. So you don't want to miss that, and you don't want to poke on it too much because you can tear it off.
Oh, okay.
Okay, 59, swelling ecchymosis, arm over biceps for 3 days after increasing golf. Okay, so there's, on these sagittal views, I think that's a T1 on the left. Not seeing much, but on the right.
This is a T2 on the right.
Okay. Uh, not sure if it's in between the muscles, kind of this lobular dark signal.
This is that signal.
Hmm.
Here's a
Okay.
T1.
Mm-hmm.
Here's a PD fast.
Okay. So that looks like, yeah, the deep muscle. So I would think that's the brachialis, and that looks like maybe there's a
edema, then
deep.
we've got this funny low signal stuff here.
Yes.
There are the axials.
Um, Again, we see edema uh within the muscle fibers, the brachialis. I think it's just a muscle tear.
Right.
Okay.
So, this is the muscle tear, and this is actually T2-weighted damage, and this is an acute hematoma within the muscle. So in the old days, we would call this a grade 2 tear because there's a fluid collection in the tear with edema around it. And more recent data say that there's really not a difference in return to play if you have a fluid collection or not. So that's the reason people are migrating away from the old definition, which was grade 1, you'd see usually kind of linear increased signal intensity between the fibers, showing edema. Often it's feathery in nature, depending upon what kind of muscle it is. Grade 2 would be where you'd have fluid collections within the muscle, and grade 3 would be a complete transection of the muscle. But generally, the clinical difference between grade 1 and 2 is most studies now show is not a big deal. So we haven't done the muscle lecture yet, have we? Okay, we'll do that, and we'll go through the other grading systems that are current right now, including the British classification, which tend to be better at predicting return to play, which is important for athletes. And so this was a brachialis tear.
All right. So it looks like we have another muscle tear of the brachialis with a hematoma.
Okay, and then a little fluid level here.
Yeah.
And here, this one is it's a little bit more extensive than the prior one. We can see the regular type tear with the edema in between the muscle fibers there, but then we've got the fluid collection here, which would make it an old grade 2. This is very extensive and was very symptomatic in this patient.
All right. So we have a lot of edema kind of medial aspect of the elbow. Looks like it's one of the flexor muscles.
Okay, good. And,
Grade 2.
yeah, this turns out to be the flexor digitorum superficialis. It's a little bit, it's kind of in the midline back here, as we talked about before. Okay.
Okay. Elbow pain. Okay, I see edema on the lateral side. Within the muscle.
So this one's 6204.
Okay.
This is actually an extensor longus muscle over there.
Mm-hmm.
It's extensor carpi radialis longus. So that's on 6204. Now the patient came back 6 days later, and this is what it looked like.
There's looks like decreased edema within the muscle.
Which muscle?
This is we're on the opposite side now. So we've
medial side.
So the lateral one looks better now.
Yeah.
And now you've got one on the medial side. So the patient continued to, I think he was a pitcher for the Angels. He continued to play through the pain and probably changed the mechanics and started favoring that and toward the other side. I think after this one, they took him out for a couple of weeks. But these kind of muscle tears tend to heal quite rapidly. We'll talk more about that in the muscle section.
All right, so a lot of soft tissue infiltration surrounding that radius.
Okay. And here, a little bit of fluid here in
Yeah,
the
bicipital
marissa.
radial
Bicipital bursitis, good. And then if we go to the coronal stir on this case, there's the stir.
Something going on at the radial tuberosity, right?
Yeah.
This traction edema, maybe
So we have this. Yeah, so this is where which muscle goes around
This
the
is the-
radius at this location. This is the supinator.
supinator.
So this is a tear of the supinator muscle.
Okay.
And here's another example of a supinator muscle tear. Here and here. Okay. This is an old low field study.
All right. So
I'll give you guys a little bit of a challenge here with these old studies.
yeah. So on the images on the right, looks like there's increased signal within the triceps.
Okay. Here.
Yeah.
There. Here we can see it here.
Yeah.
Okay, so this is probably tendinosis. These are old studies. Actually, it was a 1.5 Tesla system, but this is many years ago, before the PD fat sets were available. Just to give you a little history there. And this is kind of a little strain. Now, with the triceps, in a study we published, I don't know, maybe 10 years ago, we did 189 MR scans in asymptomatic adults. And what we found is the striated appearance like we see back here was seen in almost all of the asymptomatic adults. The uniform increased signal intensity, which we see here, was not seen in the normal adults. So this kind of uniform signal intensity is abnormal, whereas this striated appearance, the triceps insertion is a little bit kind of like the brachialis insertion, but in that you have both muscle fibers and tendon fibers at the insertion. But with the triceps, the vast majority, 90%, are generally fibrous, whereas at the brachialis, sometimes you'll have 90% fibrous, but other times you'll have 90% that are muscular. So there's variation there. But this uniform abnormal signal intensity here is abnormal. Okay. Yeah. Okay.
Okay, so here we're in the posterior elbow. I see in the right image edema within the muscle fibers.
Here's a T1. That's
Yeah.
what edema looks like on T1, a little bit subtle there.
Yeah.
Not so subtle on the PD fat side. We go to the actives.
Yeah, it looks like edema within the muscle fibers of the,
So what
Triceps.
I'd say a grade 1 muscle strain of the triceps.
But the patient was hit by a pitch.
Okay,
So this is actually a contusion.
okay.
Wouldn't you call it a contusion?
Contusion, I don't think we can clearly differentiate contusions from low-grade tears on MR, but the history was a contusion.
Yeah, I would think so, because just from the history and those guys lying.
Yeah.
And besides that, the fibers are torn or injured posteriorly, but not near the bone.
Yeah,
So
yeah, this,
what's interesting is the skin is not too much injury there. You ordinarily would get a big lump there.
yeah. Yeah. They offered to give me the video of the time. I should have said yes, but I didn't. But this is probably right where the ball hit directly here, and then this is kind of indirect hemorrhage.
They ice these right away, and that works pretty good.
Yeah. So, right. Yeah, I don't think he missed a game, but it was painful at the time. But this is typical of contusion. This is the center part, and then the kind of peripheral hemorrhage. as opposed to a grade 1 strain, which looks like this. And typically grade 1 strain, so you can see it looks kind of similar in this diffuse edema, but with grade 1 strains, especially for these kind of muscles, you very characteristically will get this edema along the muscle fibers, as opposed to just centered here in a conglomeration. Now, I don't know that you could reliably in a large series differentiate contusions from grade 1 strains by using these criteria, but this is typical of contusion, and this is typical of a grade 1 muscle strain as a strain injury rather than a contusion. And both of these tend to heal quite well. There's a little bit of fluid here and this is probably more in the subcutaneous fat in this patient with a muscle strain. So we'll keep going progressively here.
All right, looks like we have an avulsion of the triceps insertion with retraction.
Yeah, so this would be a complete grade 3 tear. Actually, the distal end of the tendon is here. If you notice, this is typical of what we see in older adults, and that clearly there's a lot of degenerative disease within the tendon. And we know, especially from studies from the shoulder that we've talked about it, you pretty much don't get tears of the tendons without having significant underlying degenerative disease. In fact, in a large cadaver study of the rotator cuff that I've talked about, every rotator cuff tear was associated with severe underlying chronic degenerative disease from tendinosis. So
Usually
that's
see
what
in
I'm seeing here.
40s to 50s.
What about 40s to 50s, John? I didn't.
That's when they start tearing.
Mm-hmm. Right.
This one looks like it may have been contused a little bit and just too much strain on it.
Yeah. You can see that there's a lot of underlying tendinopathy.
It almost looks like there might be some bone involvement too.
I don't think there was in this one, but I can't guarantee it because this was a long time ago.
All right, so again, looking at that triceps region, it looks like there's a full thickness tear of the triceps and a big hematoma adjacent to the fluid collection.
With a nice.
What would you do with it?
I mean, I think this would probably refer to surgery and maybe they could reattach it.
Well, you have a piece of probably tendinous portion of the muscle attached to the olecranon there on the tip. We don't have any other acquisitions, so if it comes off the bone, it's easy to fix. If it doesn't, it may be a little more difficult, but that's fixable. But you would have to leave the arm in extension for a period of time, and that people don't like to do that very much.
Okay, so here, again, looking at the triceps, looks like there's a complete tear. The superficial fibers, the adjacent edema. The bone, the olecranon doesn't look completely intact. Be worried
There
about
probably
maybe.
is an avulsion there,
Yeah.
right there where John is pointing. And that's an easy one to fix with a couple of screws.
Yeah, so this is a bony avulsion. And John, so why is it important for us to tell you that it's a bone avulsion?
It is. You want to pick your instruments.
Yeah. So
Although I like drill holes and sutures myself, but if you're dealing bone to bone, I like the little screws. They work very well.
yeah. And the Results
because you
are,
can do it.
yeah,
You can do it faster that way.
and the results are more reliable when you have bone-to-bone healing, as we talked
Well,
about.
it all depends on which screws you use. If you use absorbable, they sometimes will absorb too quickly, and then you get a recurrence.
Okay,
So you got to be a little careful about using the resolvable screws in these conditions where the tendons can pull through.
thank you. So this is an acute avulsion, which heals quite readily. Easy for us to say. What do you think about this one, Tayson?
Well, yeah, the triceps is avulsed, but that fragment looks a lot more mature and than
Yes.
the previous
Indicated
one.
here, yeah. And the olecranon, we don't see any acute edema here.
Yeah.
Yeah, so this is a chronic avulsion. And now the other thing to notice here is that this is one part of the triceps, but what's happening here?
Guess that's our anterior head is
Right.
still intact.
So actually the medial portion, and not uncommonly in the triceps, you'll have both mostly a fibrous insertion dorsally here, but not uncommonly you'll have a muscular insertion more anteriorly. And the muscle, can give a lot more. So it's not rare that you'll have a tear of the tendinous portion, but the muscular portion will still be intact. And I don't know if that makes the repair more likely to succeed or not. But it's worth commenting on in your report.
I couldn't tell you, John, but that's not a difficult procedure to fix that.
Good, good. So that's somewhat chronic.
This one looks more acute. There's I guess, an avulsion of the distal triceps and a lot of edema in the olecranon.
Yeah. Actually, with this one, this patient had been symptomatic for over a year. We've got a lot of eburnation in the bone here that we can see the defect there. We don't really see a good bone fragment with the tendon itself. And this was actually more of a long-standing chronic avulsion here. With erosive changes to the olecranon, we see a lot of edema here as well. This particular patient.
You would need a autologous, autogenous graft for this. I don't think you could fix it but by itself.
Okay, thank you. Okay, well, I think we're finished with this lecture. John, I'm going to close out here, and then I'll come back on, and we'll start the next lecture. Okay?
Okay, I'll go out and come back.
Okay.